So before we get into the chest tube itself, let's just do a little bit of review here and why we're doing this. So this is the thoracic cavity. We've got 2 lungs, the diaphragm here, these are the ribs. Okay, this in the middle, this is called the mediastinum, right? What do we have in the mediastinum?
The heart.
The heart. Did you say cartilage? Yep, there's cartilage. What supplies the heart with blood?
Pulmonary arteries.
Yes, yes, we've got superior and inferior vena cava bringing blood back, and then the aorta takes blood away, so that's important. There's a lot of things happening here. The green here represents that pleural space, the lining actually, and that little bit of fluid that is in between the 2 layers that surround the lungs. One layer, visceral, goes up against the lungs. Second layer, parietal, is up against the chest wall and the mediastinum. There's fluid in there so that when we breathe in, diaphragm goes down, lungs expand, it doesn't hurt, right? And we breathe out, opposite happens. When we breathe in or when we are bagging somebody, it's called PPV. What does PPV stand for?
Positive pressure ventilation.
Positive pressure ventilation. So we are forcing positive air into the lungs to help them expand. Well, the thoracic cavity also has pressure. And we need that pressure for the diaphragm to go down and then to recoil. If it's positive going in the lungs, what do you think it is outside of the lungs? Think it's positive or negative? Negative, absolutely, yes. And when you lose negative pressure, the lung collapses, it can't expand, and that's why you need a chest tube. There are lots of reasons we could lose the positive pressure. What do you guys think those are?
Injury.
Injury, yes. Trauma, broken ribs, people fall all the time. Yep, ribs 4 through 9, most likely to have a punctured lung.
Surgery.
Surgery, yes. People who have lung cancers, it could be slow growing, fast growing, or maybe they had a surgery, an abdominal or a thoracic surgery, and we just needed the tubes. For the most part, we're not going to see those. We'll see like the traumatic ones, like you said. Our COPDers, right? If they have a little blood that bursts, we can see the need for a chest tube.
Central line insertions.
Yeah, there could be a little nick, unfortunately. Yep, we could create
Notice
that.
it 6 hours later.
Yes, yes. So lots of reasons to need it. So let's talk about our unit now. Avita has the same Pleurovats at every location, which I just love. Teleflex makes ours. It's called the Sahara. What is the Sahara outside of work?
Desert.
Yes, what kind of desert?
It's a dry desert.
It's a dry desert.
Dry
And that's important because we have dry suction and we have a dry seal, which means we don't need water for the seal, we don't need water for the suction. Let's talk about that. Suction is controlled by a dial here. It's preset by the manufacturer at 20. You're probably never going to touch that. Just know, it does change. And then we have a one-way valve. It's kind of like a flutter valve or a Heimlich valve. It lets things out of the patient into the collection chamber, but it doesn't let things from the collection chamber back into the patient. We don't need water to establish either of those. And that's when most people say, okay, Katie, what about this part down here? You need water there. Yeah, so that's our air leak meter. This tells us if we have an air leak and how bad it is. And we go really simple. Little number 1, little air leak. Big number 7, big air leak. When you put the water in here, it comes on a pre-filled syringe on the back. You inject it, it even tells you needleless injector site here. There's a blue dye in here, the water will turn blue. And you will see 2 types of movement. The first one is called tidally. That's when the water moves up and down with inspiration and expiration. And it's simple. I think when we breathe in, they're sucking that water up. The water moves up. When they breathe out, they push the water down. That's rhythmic, and you should see that consistently. We want to see that. The second type of air movement or water movement you might see is bubbling. And it could be 2 types. It could be intermittent. When we have intermittent air leaks, I want you to think of coughing, deep breathing, and moving, which is why when you assess your patient, we tell them to turn their head and to cough and deep breathe so you can see if there are air bubbles. And that just gives you more data to chart. You've got to chart that though, okay? If you had consistent air bubbling, that would tell you that you have a consistent air leak. What's really important is that you pay attention to where those end. If it's consistently a 1 or a 2, maybe not a problem. If you've been charting all shift, it was a 2, and now suddenly it's a 7, you have a problem that you need to investigate. And we'll talk about troubleshooting the air leaks a little bit later. But that's our air leak meter. Questions? Excellent. Next chamber is our collection chamber. If you have a pneumo, do you expect to see anything in here? Just maybe a little bit after the initial insertion from like drainage, because sometimes it's a blood bag, but no. But if it were a big hemo, we would absolutely expect to see blood in here. If it were a big gross empyema, we'd see something in here too. When this gets full, what do? Change it, yeah. Where do you put this once you change it out? Biohazard. Absolutely biohazard. Okay, do we have any questions about the collection chamber? Coming over here, there's a little window here and it has an orange float. And this says that if you hook it up to suction to establish this amount of pressure, you need to see the window, the float in the window. That means that I hook this up to suction and I turn it on. When I've established this much pressure, negative pressure, 20 for example, the orange float will appear in the window. If you have it on intermittent suction, what do you think the float will do?
It sets until you.
Till it turns back on, yeah, so it'll go up and down. Yes, you were correct. And we would expect that. There are different reasons to put people on intermittent versus continuous suction. Somebody who has a big hemo and they have a lot of blood we need to evacuate is probably going to need some help with suction. That's a provider's decision. You don't have to decide that. Make them decide that, okay? And let's turn it over. So we got orange on the side, so you can put it on the side of the wedge transport. Looking at this, and it's labeled, this is for suction. This is that needleless injector site for us to put the water in the air leak meter, and then this is a negative pressure release button. You can release negative pressure out of this, and here's when you might want to. If you had this at 40, and the doc said, you know, I think we can turn the suction down to 20, and you turn it down to 20, you have a pressure gradient now, this will let the negative pressure out on its own. It'll do what it's supposed to. But if you're worried that you're going to create, say, maybe a tension pneumo or something because you have so much tension on it, you could push this button letting pressure out. But I'm going to caution you in that because you have no way of knowing how much you're letting out. And that's the disadvantage to this model. If we had water suction, and I'm not saying we need it, I'm just saying water suction has a water level, and as you push this, the water level would go down. You will probably never touch this, and I'm going to caution you in using it just because you don't. There's no way to tell. And if you go to atmospheric pressure, you're going to create an even bigger problem. Okay? All right. So that's the unit. Here's our patient. He just had this inserted and he came up to the floor. There's no policy that says they can't go to the med-surg floor. Typically, they're going to be pretty stable patients. But you get this patient. What do you want to do? I know you said you work med-surg. What do you want to do when you get this patient up to you? I know exactly. You know what you do. You're going to go in the room, right? What are you going to do when you get in the room?
Assess it.
Yes. How are you going to assess it? Go with it. You do know. How do you assess patients normally? With their lungs. Yes, okay, we'll start with the lungs. You're going to listen. I like it, so we're going to listen to the lung sounds, right? Would you expect to hear lung sounds on this side of the chest tube?
Maybe diminished.
Definitely diminished, maybe nothing if it's collapsed and it can't expand. Yes, and then as it starts to improve, you're going to start to hear them. That's why assessment, trust your nursey sense. If you hear no sounds, there's probably no sounds. Listen to the other side. So they said they want to listen to the lung sounds. I like it. What do we want to do about this?
Is it occlusive?
It should be, right? It should be occlusive, yes. So we want to look, you said, at your dressing. We want to make sure that it's occlusive. Occlusive meaning it doesn't let any air in, right? Yes, I like it. We do not have a policy, but these dressings can go up to 72 hours. A provider should be changing them. They should be looking at it. Dressing changes are painful for our patients. If you go on Dynamic Health and look at all the chest tube resources, one of the studies they highlighted on the dressing change specifically said that patients did best with a silicone-based foam-backed dressing. Now, we don't have that silicone-based dressing, but we do have foam tape. So if there's a good chance you're going to see foam tape, please use it. Go grab some, because that's better for our patients' comfort. So you said you want to look. What else do you want to look for? Do you want to feel for anything?
Crepitus.
Yes, crepitus. What does that tell us?
There's air bubbles.
Yeah, there's an air. It tells us if there's an air leak. And an air leak means air's getting where? Yes. But also out. Not
into the tissue. Yeah.
Into the tissue. Yes. Yes, very good. So we've looked, we've listened, and we did a feel. And that's our assessment. What else would you do? And you may delegate this to a PCA when you get a new patient come up for an admission. Yes, vitals. And vitals are so important because they are the first thing that's going to tell us something's wrong with our patient. It's so important to know their baseline. These people are probably going to have some pain. They just had a chest tube inserted. They could be a little anxious. They can't breathe. They could be a little hypoxic. They had a collapsed lung. So for you to get a baseline, also on the BP and the heart rate, is going to be so important. So we got that. Let's talk about,
Vaseline gauze, are they still using that?
we'll talk about that, yeah. So that Vaseline gauze creates an occlusive dressing. There is some evidence that says long-term Vaseline gauze, and this used to be a hill I'd die on, not anymore, makes skin macerated, which can
Oh, yeah.
kind of interfere with wound healing. It's also not great for the sutures. Not a ton of evidence yet, but there was a study that showed that it is referenced on Dynamic Health. So you got your patient, you did your assessment, and now they gotta go down to CT. There are some things you should probably take with you. I call this my insurance policy. What do you want to gather? Oh, I like this, yes. I feel like Edward Scissorhands. Yes, so we've got our hemostats, these are rubber tipped. If you can't find those, grab some 2x2s, take them around. One pair is good, 2 pairs better. I like that. What else do you want?
Taking a dressing, like,
Yes.
just in case.
I heard an inclusive dressing. Yes, so I got my Vaseline gauze. I like an ABD, I'll throw that in there. Some people like split gauze, I have that too, okay? Anything else with your dressing?
Tape.
Yes, tape. Here's my phone. Tape. Okay, anything else? Maybe one other thing.
Are we doing some saline?
We
Are we
are.
taking that with?
We're gonna
just in
take
case?
we're gonna take this with us, yes. Yes, so you've got your insurance policy put together. Where do you want to put this when you're transporting them?
In the bed.
It's a great idea. Head of the bed behind them, or in a bag in between that patient's knees for easy. I do recommend that you put a pair of knees in your pocket though.
Yeah.
Okay? And then everything else in the back. Okay, you get them down to CT, you move them from one bed to the other one, and your tube gets ripped out partially. So now we have the holes, those are called fenestrations. They're out of the patient. My face looks like that too.
Right.
Oh boy. What do we want to do?
Cover it.
Yes, occlusive dressing. Yes, so I got my Vaseline gauze. Have any of you ever tried to tape this? It's slippery, it doesn't tape.
It is, you're gonna put your ABD or pull that bar over it and you're gonna,
Yes. And tape it. How do I tape this?
you're gonna leave us. Yes.
4 sides.
3 sides.
3 sides.
Oh,
Do
3
3
sides.
sides, yes.
Yeah.
Yep, and this is where people say, well, how are you going to tape it? You could do edges, borders if you like that. You could go straight across like this, as long as you've got one side open. Yes, I like it. And then what? Because now we have potentially created a buildup of pressure in here, and we want to let something happen. It's a great question, and that's how that does that. You did this. What else are you going to do? And I know you're going to do this.
Clamp it.
We're not clamping. Nope. Nope. But your patient, something just happened. You had like an event. What do you typically do when something changes in your patient? Yes. And
Notify lungs now.
yes, you're gonna assess your patient and get vitals, and that's gonna tell you if you can go back upstairs, notify your provider, or if you can call an RRT. I see you're thinking.
No.
Okay, you're good. Okay. Okay. So that's if it's partially ripped out. Let's say it gets completely ripped out. Now what do you want to do?
You're gonna hit the code, you're gonna be doing something, because someone's
Same
coming
thing.
to help.
Same thing. Occlusive dressing.
Dressing's on.
Occlusive dressing, assessment, and then vitals. And that determines if you need to call your RRT and get more people here, like you said, or if you can go back up. Depends on your shift, right? Depends, is the provider there? Do you have access to somebody? You'll have to think about those things. Yes. Okay. But that didn't happen. Let's say we made it over to the bed, and CT is moving in and out, okay? And you've got everything connected, but this disconnects. Now what do we want to do? Okay, so I'm grabbing them out of my pocket because I put them in my pocket, right? And we're not delaying anything. Okay, it's clamped now.
You're assessing the patient, by the set and listen to your lungs.
So clamping, we don't want to do any longer than 60 seconds. There's something I can do in between assessing my patient.
You clean your tips before you touch it?
So somebody asked me that, well, why couldn't I just reattach it? I don't know if you have anything in here to clean with, and if this broke, we may not be able to reattach. There's something else we could do. You asked me to bring this. This is the time we're gonna use this. Yes, so I'm gonna stick this down in the water to create a water seal. So things can get out of the patient, nothing gets back in. The goal is always to have a closed drainage system. This creates a closed drainage system. So it's in my water. Notice my clamp is still on. Is there anything else you want me to do? I just dropped that in the water. Yes. Yes, but let's say I forgot and he was clamped for like a couple minutes. Tension was building up, lots of pressure. What could I create if I don't unclamp that?
Death.
via tension pneumo.
Tension pneumo.
Yes, and we know that as tension builds, it's going to shift some things. And most people think, oh, I'll see that shift, that mediastinal shift, but that's actually seen on chest X-ray, and it's difficult to see, and it's late. It is the latest sign. So what you're first going to see is hypotension and tachycardia, because remember we said lung pushes up against the mediastinum, the great vessels are compressed, they don't have any venous return. There's no blood pressure. That's why it's so important to get vitals. But that didn't happen because you remembered it on plan. So you drop that in the water, you assess your patient, you called your RRT, you got back upstairs, somebody brought you a new unit. Yes, you did the things. Perfect. That's perfect. So, but none of that happened. You got down to CT. Go ahead.
Would they bring a new unit
Potentially, yeah.
instead of just bringing the tubing?
Yes, because this is attached. This all comes, this disconnects, and this is where you would have to decide when you're changing a unit. If everything worked well, I would disconnect here. But if it disconnected here, I would want this to be new, including my 5-in-1 connector. I would want a new one.
Right.
Yes.
But that tubing doesn't come
Separate.
itself?
No.
Oh, okay.
No. Great question. No, it does not.
Okay.
You got down to CT, you came back upstairs, results are good. The doc says, great news, it's time to take this thing out. The doctor may or may not have you be present. So let's just talk about both ways it could happen. One, the doc, what's your name? Emily. The doc walks past you. Emily, I took the chest tube out in 6. What do you want to do?
Right.
What are you going to do?
I run into the room.
Probably a fast walk. Yeah, just what do you want to check? Yeah, what do you want to check?
Does the doctor always leave those out?
This is not a nursing, within the scope of a practice of a nurse, mid-level or higher.
Okay.
Great question.
Okay.
Yeah. And if you're being asked to, that needs to be a firm boundary. It is not within the scope of a nurse's practice.
Do they
You said
still,
you were
do they suture them in here all the time?
I was gonna say,
Some
Avita?
suture, you may, so,
Okay, so it's not an Avita issue, it's a personal doctor issue.
what is that?
I'm just putting
When
it
do
in
they
the
do
suture.
it?
Yes, yes,
It's
their
not a
technique is,
policy that they're sutured. Got it, okay.
There is no chest tube policy.
yeah, yeah. Yes.
Mm-hmm.
So you said you want vitals, I like it. We're gonna probably, one of the things we always do, we look, listen, feel, right? We're looking at the dressing, yes. We're listening to the lung sounds, we're feeling. By the way, that's a painful procedure. So if you can, advocate for some pain management. If you can't get any pain management, you can put ice packs on it. That is alternatively acceptable. But let's say the provider said, hey Emily, I'd like to take the chest tube out in 6, but I need your help. Can you go grab these supplies for me? What do you think you're grabbing? Yes, dressing. You said they might be sutured in. What do you want for that?
Suturing.
Yes, suture removal kit, absolutely. So that's a good question. They may or may not clamp this. If this is established, resolved, my guess is they are going to clamp. I sure hope, and I think it's a good idea that you get those. But I don't get to decide a provider's practice. What else do you think? Maybe a chucks, just in case to tuck under the patient. Your primary responsibility is probably going to be positioning, right? So we want them sitting up 30 to 45-ish degrees. And when they take this out, we want them to vagal down. Or, because sometimes patients just don't understand what we're trying to tell them, have them focus on a long exhalation. So not but a really forced, long, and practice a couple times. Deep breath in, deep breath out, and have them push through their lips if they can, so they can remove that. And then dressing, assessment, same thing. So that's removal. And let's see. Teleflex makes this great resource, which I love, and for you, especially working on the med surg floor, you probably see 2 a year, maybe, and that can change, that can vary. But this has all the labels of the pieces and parts on it, set up directions. There's only 3 things to do to set one of these up. There's some information on how the unit works, and then some troubleshooting. This QR code, though, if you like to learn, and you want to learn more about this unit in particular, they offer a CD, which I started and stopped, but it was really good. And if you're like, I just need a little bit more, I highly recommend you scan that and consider doing it. What questions do you guys have for me right now?
Where are they?
This will be sent to your leadership so that they can put them where they want. That'll be one of the follow-up things we do. Yeah. Any other questions?